Hi, this is Brian Kim. I'm going to share with you the safe and easy way to rotate the Toric IOL counterclockwise. When the Toric IOL was introduced, we were all taught to rotate the Toric IOL clockwise only, the idea being that the haptics are designed to rotate clockwise, so don't rotate them counterclockwise. But really, that's not true. And, if you miss it by, 10 degrees, you have to go all the way around. It's a little bit tedious. And so this is really the very safe and easy way to rotate the toric IOL counterclockwise. And in my opinion, the best way to handle this situation. You can see the toric marks that I made while the patient was upright. I use a corneal marker, which will help me to center and size my rhexis. I make my paracentesis incision first on the right side and then the left side, making sure the incision is flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine and then some dispersive viscoelastic to fill the chamber. I'm using the cannula to hold the eye, and this is the triplanar corneal incision. Make a vertical groove, place the blade into the deep part of the groove, turn the eye away from me, tunnel through the cornea, turn the eye toward me, and then enter. By using the cannula, I can control the eye and control the length of my incision. I push some more viscoelastic at the end, and this is the puncture style rhexis. Using the forceps, I puncture in the center. The tear went a little bit to the side, which is fine. Go ahead and grab the right edge of the tear and start to pull to create a flap. And I use that mark that I made earlier and try to follow that, which will hopefully help me to center and size the rhexis. So after I finish the rhexis, I burp some viscoelastic out. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, turn the tip up, decompress on the left side, turn the tip down on the right, and it spins nicely there. This technique is quite consistent in achieving nice hydrodissection and being able to spin the lens. Irrigate the surface of the cornea, adjusting my sleeve. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. Place the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically, sub-incisionally. Bringing both instruments together, which crushes the meat of the lens. That's the double chop. Placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip and crushing the right heminucleus in half, and that is the cross chop. Using some vacuum as well as a chopper to lift that first piece up out of the bag and then emulsifying that first quadrant. Placing the chopper around the second quadrant, pulling it centrally towards the phaco tip and bisecting that lens piece, and then emulsifying the fragments. The key is using the chopper to get around the lens piece and then using mechanical forces to crush the lens between the instruments. By using crushing forces, you can spare the amounts of usage of ultrasonic energy and vacuum. This is a very controlled and systematic technique. I turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally and crushing it against the phaco tip, and then emulsifying the lens pieces. Doing the same thing to the fourth quadrant, crushing the lens pieces into smaller pieces, and then emulsifying the lens pieces. Using some vacuum to grab that last fragment up. And all the endonucleus is out, and then I'm removing the epinucleus, which tumbles out nicely, making sure I keep the chopper deep in the bag as I remove it. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye and a handpiece. Start sub-incisionally removing the cortical material from anterior to posterior, going around circumferentially, trying to peel again from anterior to posterior. If you peel from anterior to posterior, you'll get a cleaner cortical removal. But sometimes that's not always the case, and so if you really do a nice cortical cleaving hydrodissection, the cortex tumbles out quite well. However, it does leave these fine wispy pieces, and so you have to go to polish mode and very carefully go around and peeling that very fine. So although cortical cleaving hydrodissection is easy to achieve with my Capsulorhexis hydrodissection technique, as you've seen, it does cause these fine cortical materials that are still in the bag and requires some careful polishing and removing of that material. It can be a little bit tedious and annoying, but thankfully with this polymer tip, it's very safe to do this maneuver. You can see there's fine lens material adherent to the posterior capsule in the subincisional space there. I'm using the cannula to pulse into the subincisional space as well. It looks fairly clean. I inject some cohesive viscoelastic to fill the bag, and then I use a capsule sweep to sweep underneath the rhexis edge of any lens epithelial cells. So this is the toric lens. It's going to go into the capsular bag using the sweep to hold the eye, deliver the lens into the capsular bag, the leading edge, go in quickly with the INA, and then turning the lens in the correct orientation, disengaging the haptics from the optic, go underneath the lens, removing the viscoelastic from within the bag. And then now I'm checking the axis, and I'm supposed to be at 165. Polishing underneath the rhexis edge, and then removing the viscoelastic from the anterior chamber and the cornea. This is a key when it comes to rotating the lens counterclockwise. As long as you keep the bag fully inflated, you can rotate the lens into the counterclockwise position without any difficulty. You can use the INA handpiece to tease it that way. You can use a second instrument. I like to use a Maltzman. You can use a Sinskey. You can even use a capsule sweep, a cannula. It doesn't really matter. You can just touch the edge of the haptic on the right side, and as you try to turn it counterclockwise, because the bag is inflated, the lens should rotate quite easily. So I remove all the viscoelastic. I'm using the Maltzman here to get under the rhexis edge, and I'm going to turn the lens. Again, I'm touching the right side of the haptic, and I'm just rotating it counterclockwise. And I'm using the INA handpiece to recenter the lens with each maneuver there. And as I do that, you can see how nicely this lens rotated. It didn't cause any traction on the capsular bag. It didn't cause any traction on the zonules. And that's because the continuous irrigation continues to inflate the capsular bag with this maneuver. You're able to rotate the lens very effectively and atraumatically. It's not touching the bag because the bag is inflated. You don't ever want to rotate the lens counterclockwise with the eye just flat, like this, like now. If you just try to use a cannula with the eye deflated or even under viscoelastic, because all you're going to do is just pull on the zonules in a capsular bag. And then when you're done, you have to remove the viscoelastic and you've achieved nothing. And so this is the most effective way. Inflate the eye with continuous irrigation. Use a second instrument to rotate the lens counterclockwise, using the INA to tease it and recenter it. You can see this is supposed to be at 165, and it's perfectly on axis at 165 with this technique. So I hope this was helpful to you, and I thank you for your attention.